Descemet stripping endothelial keratoplasty is a selective replacement of the diseased endothelium that enables us to achieve quick visual recovery due to a predictable refractive outcome and helps preserve the structural integrity of the globe, thus offering lifetime protection against graft-host dehiscence and amblyopia. Pediatric penetrating keratoplasty poses several challenges due to the small size of the globe, reduced corneoscleral rigidity, positive vitreous pressure, and postoperative complications like severe inflammation, secondary glaucoma, immunological graft rejection, suture-related problems, graft infections, and amblyopia related to higher astigmatism. Although isolated endothelial dysfunction is relatively rare in the pediatric age group, as a large proportion of pediatric penetrating keratoplasty are performed for endothelial dysfunction, Descemet stripping endothelial keratoplasty could offer distinctive advantages in these cases. A suitable candidate for DSEC would be one with isolated corneal endothelial decompensation such as congenital corneal edema, including congenital hereditary endothelial dystrophy (CHED), primary congenital glaucoma with corneal edema, and Axenfeld-Rieger's anomaly, acquired non-traumatic corneal edema, endothelial decompensation following failed penetrating keratoplasty, pseudophakic corneal edema, or endothelial damage from intraocular surgery, acquired traumatic corneal edema, blunt corneal trauma, that is, birth trauma due to forceps injury, insect bites with keratouveitis. To take the necessary preoperative measures, ensure that you have a pediatric anesthetist in your team. Position the child with the head slightly higher to reduce positive pressure. Reduce the intraocular pressure by hyperventilation and use a pediatric speculum to avoid pressure on the globe. The preoperative evaluation helps us to estimate the visual acuity, density of stromal scarring, type of cataract if any, and intraocular pressure. One must look for nystagmus and posterior segment pathologies if any, and calculate the axial length measurement and intraocular power. The preoperative evaluation is difficult, requiring a detailed history of the onset and duration of the endothelial decompensation to help estimate the depth of amblyopia. If the infant is less than a month old, measure the current visual function by assessing the response to light. For an infant aged between 1 to 6 months, measure it by fixing and following light, and in older infants by checking the fixation to light. In older children, teller acuity cards or preferential looking may be used. Examination may be carried out either by restraining the child or by using sedation or anesthesia. A handheld slit lamp or microscope is used to measure the corneal diameter and perform refraction. The intraocular pressure is measured with a handheld tonometer. Older children usually cooperate in a slit lamp examination. An ultrasound B-scan of the eye is done if the fundus is not visualized. As pediatric transplants are associated with a high rate of allograft rejection and a graft failure could increase the chance of amblyopia, an excellent donor tissue with the highest cell density is preferred from a young donor between 4 to 30 years of age. Donor lenticule can be prepared by using Muraya ALTK system, manual dissection using a Barron's artificial chamber, or femtosecond assisted dissection. The superior incision is safer as it is protected by the eyelid. A 4 to 5 mm long scleral incision was made to facilitate the implantation of the donor lenticule. Trypan blue stained Descemet's membrane was scored within the mark made on the epithelium using the reverse Sinskey hook. Descemet's membrane was then stripped by using pediatric capsulorhexis forceps or automated irrigation aspiration cannula. Additional procedures if any, that is synechiolisis, peripheral iridectomy, lens aspiration, primary posterior capsulotomy, or vitrectomy. Two may be required in special situations. The sheath's glide was inserted through the scleral tunnel across the pupillary area to prevent inadvertent injury to the lens. Deep anterior chamber was achieved by injecting an air bubble or saline or using an anterior chamber maintainer. Appropriate sized donor lenticule was placed over the sheath's glide, coated with cohesive viscoelastic device, and was then facilitated inside by either push-in or pull-in technique after centering the donor lenticule to the marked area on the corneal surface. Sterile air tamponade was maintained for 7 to 10 minutes. Complete removal of the viscoelastic device helped to reduce post-operative interface fluid, thus minimizing the dislocation rate. Fluid air exchange was done to overcome pupillary block. Finally, it was ensured that the surgical wound was watertight. In children, all incisions are sutured to prevent leakage due to low scleral rigidity, and also because children are more likely to injure themselves. There are higher rates of post-operative complications like glaucoma or reoperations such as rebubbling or cataract extraction or membranectomies. Procedures like synechiolisis, pupilloplasty, and peripheral iridectomy too may be required in special situations. Education of parents in post-operative care ensures that they are aware of the warning signs to watch out for, the method of instilling eye medications, and the importance of examination under anesthesia once every 3 to 4 months in the first year to check for refraction, intraocular pressure measurement, and fundus evaluation. Periodic change of glasses and appropriate patching when required can lead to successful outcomes. The visual outcome of pediatric endothelial keratoplasty is quite encouraging, mainly due to undisturbed globe integrity, early visual rehabilitation, and lower risk of allograft rejection. Remember, surgery is just the beginning of the child's vision rehabilitation journey. How well the child will be able to see depends on the age of onset of corneal edema in the child and its causes, laterality, type of optical rehabilitation, and furthermore on amblyopia therapy or post-operative complication. In this video, we described the indications for pediatric endothelial keratoplasty and highlighted the differences between adult and pediatric grafts, focusing on pre-operative evaluation, surgical technique, and post-operative follow-up.